Welcome to the Deep Dive. Today we're looking into adrenergic receptor blockers.
That's right. These are drugs that basically put the brakes on parts of your sympathetic nervous system.
Yeah, the fight or flight system, as people often call it. We want to figure out how these medications actually pull that off.
Exactly. We'll be diving into the different kinds, what they're used for, the conditions they treat, and crucially, the safety stuff you need to be aware of.
For this deep dive, we've, gathered info from various places, classifications, how they work on a cellular level.
Their clinical uses, safety guidelines, the whole picture, really.
Our mission here is to try and make this potentially complex topic feel clear and insightful.
Yeah, cut through the jargon. We want you to come away with a really solid grasp of these blockers, feeling, informed, not bogged down.
Okay, sounds good. So let's start unpacking the alpha blockers. That's one of the two main groups, right?
Correct. Alpha blockers, they work by getting in the way of alpha receptors.
The docking stations you mentioned.
Precisely. Docking stations for the chemicals that drive that sympathetic response. Block the stations, you block the effects. Simple as that, well, almost.
And it's not just one type of alpha blocker, is it? I remember seeing different categories.
You're right. We split them up based on what they target their selectivity. So first, you've got the non-selective ones. They hit both alpha-1 and alpha-2 receptors. Think phenoxybenzamine and phentolamine.
Okay, both types.
Then the selective alpha-1 blockers, drugs like Precautions and tamsulosin. And finally, there are selective alpha-2 blockers, though less common in this context, like yohimbine.
Got it. Let's dig into those non-selective ones first. Phenoxybenzamine, what's the story there?
Right.
Blocking both alpha-1 and alpha-2.
Right. The really interesting thing about phenoxybenzamine is its action is irreversible.
Irreversible. Wow.
Yeah, it binds super tightly to those alpha receptors, both 1 and 2, and basically takes them out of action for a long time. It's like, super glue.
Okay, so why would you want such a permanent effect?
Well, it's incredibly useful for managing patients before surgery for pheochromocytoma.
That's the adrenal gland tumor, right?
Yeah.
Causes massive adrenaline surges.
Exactly. Dangerously high blood pressure. So, phenoxybenzamine provides that really strong, sustained blockade needed to control the pressure before the surgeon goes in.
Okay, powerful tool for a specific job, but irreversible sounds like it could have downsides too, blocking everything so completely.
Definitely. Because it hits alpha-1, which helps control blood pressure, you often see significant postural hypotension.
That dizzy feeling when you stand up.
Yeah, blood pressure drops sharply. And the body might try to compensate by speeding up the heart that's reflex tachycardia. So those are common side effects.
Right, makes sense. Powerful but broad. What about the other non-selective one, phentolamine? You said its action is different.
Yes, phentolamine is reversible. It binds, does its job, but then lets go. The receptors can function again.
So more like a temporary block.
Exactly. That on-off nature makes it useful for things like hypertensive crises, where you need to lower blood pressure fast, but controllably. And it's also the go-to for counteracting tissue damage if certain other drugs, alpha agonists, accidentally leak out of a vein.
Extravasation. So phentolamine can block the damage from the leak.
Precisely. It reverses the local effects of that leaked drug.
Okay, that makes sense. Reversible gives you more control in those acute situations. Now, what about the selective alpha-1 blockers? Precautions, tamsulosin, what's the benefit of being more targeted?
Well, focusing just on alpha-1 gives you more specific effects. Take Precautions. It's interesting because it treats both hypertension,
high blood pressure,
right, and also BPH, benign prostatic hyperplasia.
Prostate enlargement in men, causing urinary issues.
Exactly. So it hits two birds with one stone by targeting alpha-1 receptors found in both blood vessels and the prostate area.
Pretty efficient. Are there any catches?
There's something really important with Precautions, the first dose effect.
I've heard of that. What happens?
Some people, the very first time they take it, can get a really significant drop in blood pressure. They might even feel faint, or actually faint. Syncope.
Wow. Just from the first pill.
Yeah. It shows how sensitive that system can be. So, the usual advice is start with a really low dose, and often take it at bedtime initially to minimize that risk.
Definitely something crucial for you, the listener, to know if starting it. Okay, now tamsulosin. That one seems even more focused on BPH.
You got it. Tamsulosin is what we call highly uroselective.
Uro, like urinary tract.
Exactly. It preferentially targets the alpha-1 receptors right there in the prostate and the bladder neck. So it relaxes those muscles, helps improve urine flow.
Yeah, without affecting blood pressure, much elsewhere.
Much less, yeah. That makes it a preferred choice for men who have BPH but normal blood pressure because you avoid that dizziness side effect more often.
That's a great example of targeted therapy. Any specific side effects linked to that uroselectivity?
Yes. The main one is something called retrograde ejaculation.
Meaning?
Instead of semen going out during ejaculation, it goes backward into the bladder. It's not harmful health-wise, but, it can be a concern for some men. Definitely something to discuss.
Okay, good to know. So we've seen the different types and how they work. Let's sum up their main clinical uses. Where do we see alpha blockers in action?
Well, connecting back, for pheochromocytoma, like we said, phenoxybenzamine is key pre-op. That irreversible block is vital there.
Right, the long-lasting effect is the goal in that case.
Exactly. For general hypertension, prazosin and another one, terazosin, are options, maybe if other drugs aren't enough or if BPH is also present.
Makes sense. And BPH itself.
That's where tamsulosin and another selective one, alfuzosin, really shine easing those urinary symptoms.
Okay. And we shouldn't forget phentolamine
for reversing those accidental alpha agonist leaks. The extravasation antidote, essentially.
And adverse effects overall, if we group them.
Broadly, the non-selective ones, phenoxybenzamine, phentolamine, they're more likely to give you that postural hypertension, maybe some nasal stuffiness too, and that reflex tachycardia.
Right, the broader effects.
Whereas with the selective alpha-1 blockers, especially tamsulosin, that retrograde ejaculation is the most distinct one to watch out for.
Okay, I think that gives us a really good handle on alpha blockers. Let's switch gears now to the beta blockers, the other main team.
Absolutely. Beta blockers, they approach modulating the sympathetic system differently. They block beta receptors.
Another set of docking stations.
Yep. But beta receptors are maybe more widespread with really big effects on the heart and blood vessels, the cardiovascular system, and the lungs too.
And just like the alphas, there are different types of beta blockers, aren't there? Selective and non-selective.
Exactly the same principle. You've got non-selective ones that block both beta-1 and beta-2 receptors. Propranolol and nadolol are classic examples.
Okay, hitting both betas.
Then you have the selective beta-1 blockers, often called cardioselective. Atenolol, metoprolol. Their big advantage is focusing on beta-1 receptors, which are mostly in the heart.
Meaning less effect on the lungs.
Precisely. That makes them generally safer if you have something like asthma or COPD, where blocking beta-2 in the airways could be problematic.
Right. And then there was a third group.
Yes, the third-generation beta blockers. These often have extra tricks up their sleeve, like causing vasodilation, widening blood vessels. Carvedilol and nebivolol fit here.
Okay, let's start with the non-selective ones again. Propranolol, that one sounds familiar.
It's a real workhorse, used for loads of things. Hypertension, angina.
Chest pain from the heart.
Right. Arrhythmias, preventing migraines, even helping with the physical symptoms of anxiety, like a racing heart. Very versatile.
But the downside is the non-selectivity, the lung issue.
Exactly. Because it blocks beta-2 in the airways, it can trigger bronchospasm tightening of those airways. Big no-no generally for people with asthma or COPD.
Okay, crucial point. Anything else with propranolol?
Yes, another really important one. It can mask the warning signs of hypoglycemia.
Low blood sugar. How does it mask it?
Well, the symptoms you rely on shakiness, rapid heartbeat, those are partly driven by the sympathetic system via beta receptors. Propranolol blocks those, so someone with diabetes might not realize their sugar is dropping dangerously low.
Wow, that sounds potentially dangerous for someone managing diabetes.
Okay, so that highlights the benefit of these selective beta-1 blockers like atenolol and metoprolol. Safer for lungs.
Generally, yes. Because they mostly stick to the beta-1 receptors in the heart, the risk of bronchospasm is much, much lower. Not zero, perhaps, but significantly reduced.
And what are they mainly used for?
Hypertension is a big one. And they're really important after a heart attack, myocardial infarction. They help protect the heart muscle going forward.
So getting the heart benefits with less lung risk makes sense. Now, those third-generation ones, carvedilol and nebivolol, you said they do more than just block beta receptors.
Right. Carvedilol is interesting because it's got dual action. It blocks beta-1 and beta-2, but it also blocks alpha-1 receptors.
Like some of the drugs we talked about earlier. So it widens blood vessels too.
Exactly. That alpha-1 blockade adds vasodilation, which is really helpful, especially in managing heart failure. Plus, it seems to have some antioxidant effects, which might add extra heart protection. So hitting multiple mechanisms.
Yeah.
Seems useful for something complex like heart failure. What about nibivolol? Its vasodilation works differently.
Yeah, nebivolol is mainly beta-1 selective, so it targets the heart, but its special trick is boosting the release of nitric oxide, NO, in the blood vessels.
Nitric oxide. Isn't that a natural vasodilator?
It is a very potent one. So nebivolol helps blood vessels relax and widen via this NO pathway. This can be great for hypertension, maybe particularly helpful for people with diabetes, and it also tends to be pretty neutral regarding cholesterol levels.
Fascinating, that extra NO boost. Okay, so we see how they work. Clinically, where are beta blockers most used? The big picture.
Well, cardiovascular health is definitely the main arena. For hypertension, atenolol, metoprolol, very common, often first-line choices.
Okay.
For angina and after a heart attack, they're vital. They reduce how hard the heart has to work, cut down its oxygen needs, which relieves angina pain, and helps limit damage after an attack.
You mentioned heart failure specifically with carvedilol. Are others used too?
Yes, carvedilol and another one, bisoprolol, are actually proven lifesavers in chronic heart failure. When used correctly, carefully titrated up, they improve survival and keep people out of the hospital. It's a major use.
That's huge. Improving survival. Any other notable uses?
Sure. Arrhythmias, fast heart rhythms like SPT. There's S-mol, given IV in the hospital, works very quickly. Then there's timolol as eye drops for glaucoma. It reduces fluid production inside the eye.
Eye drops, okay.
And hyperthyroidism. An overactive thyroid can cause tremors. Fast heart rate beta blockers like propranolol help manage those symptoms.
Wow, quite a range, from the heart to the eyes to the thyroid. But we need to talk downsides again. Adverse effects of beta blockers.
Definitely things to watch for. Cardiovascularly, they can slow the heart rate too much, bradycardia, and sometimes, especially if started too quickly or in vulnerable patients, they might initially worsen heart failure symptoms. Careful dosing is key.
Okay, and the lungs.
Bronchospasm, as we hammered home, especially with the non-selective ones, that's why they're generally avoided in asthma and COPD.
Right, and the metabolic issue.
Masking hypoglycemia symptoms in diabetes, that's a critical one to remember.
Any others? Brain effects?
Some people report fatigue, maybe feeling a bit down or depressed, though that's debated sometimes. But fatigue is pretty common.
Okay, so a fair few things to monitor. Are there absolute no-go situations? Contraindications?
Yes. Asthma-key PD is a big one for non-selective agents. Severe bradycardia or certain heart blocks where the heart's electrical system is already faulty. And a specific type of angina called Prinzmetal angina.
Got it. What about mixing them with other drugs? Interactions?
Oh, definitely. Combining them with certain calcium channel blockers like verapamil can really depress heart function too much. Big risk there.
Okay.
The interaction with insulin and other diabetes drugs, masking hypoglycemia, we covered that, but it bears repeating.
Crucial point.
And maybe less dramatically, NSAIs, things like ibuprofen, might slightly reduce how well beta blockers lower blood pressure in some people.
Right, common painkillers. Good to know. Lastly, stopping beta blockers. You can't just quit them cold turkey.
Absolutely not. Stopping them abruptly can trigger a nasty withdrawal syndrome. You can get rebound angina, even increase your risk of a heart attack.
Wow. So what's the safe way?
It has to be gradual tapering. Reducing the dose slowly over time under medical supervision lets your body readjust safely. Very important message.
Definitely. Okay, we've covered a huge amount on both alpha and beta blockers. Let's try and boil it down. Key takeaways. Clinical relevance.
Well, the fundamental difference, just to recap, alpha blockers mostly work on alpha receptors, causing vasodilation, relaxing smooth muscle in places like the prostate. Beta blockers hit beta receptors, big effects on the heart rate, pressure, force.
And you have those clinical pearls, the really practical nuggets.
Yeah, a few key ones. First, pheochromocytoma. Always alpha blockade before beta blockade. Absolutely vital to prevent a hypertensive crisis.
Alpha before beta. Got it.
Second, asthma group ED. Avoid non-selective beta blockers. If you must use one, choose a beta-1 selective agent and use it very cautiously.
Okay, caution with lungs.
Third, BPH in men with normal blood pressure. Tamsulosin is often preferred due to its uroselectivity, less impact on BP.
Right, targeted treatment.
And fourth, heart failure with carvedilol. Start low, go slow. Gradual dose increases and close monitoring are essential.
Those are super helpful practical points. So summarizing the main uses again, alphas for hypertension, BPH, pheochromocytoma, betas mostly for cardiovascular conditions, but always keeping those lung risks in mind.
Exactly. And for both classes, you absolutely need to monitor for side effects, hypotension with alphas, bronchospasm, and hypoglycemia, especially with betas. It's all about balancing benefit and risk.
Well, this has certainly been a deep dive into adrenergic receptor blockers. We've looked at, how they work, the different types, where they're used, and those really critical safety points.
Yeah, we've covered a lot of ground. It really shows how we can strategically tweak the sympathetic nervous system to manage so many different health issues.
So, as you think about all this, the different receptors, the selective drugs, the non-selective ones, it really makes you wonder, doesn't it? What does the fact that we can target these systems so precisely tell us about, well, the incredible complexity of our own bodies and how far medicine has come in figuring out how to modulate these intricate controls?
It's pretty amazing when you think about it that way, the level of control we can achieve.
Definitely something to ponder. Thanks for joining us for this deep dive.